Good evening and welcome everyone. We are thrilled to host you at another Constele Inari webinar, proudly presented by Veiva Scientific. This platform brings together global experts to share insights on advancements in vascular therapies and interventions. We are privileged to have a distinguished panel of interventional cardiology. So the chairperson for the session is Dr. D.S. Chadda, sir, who needs absolutely no introduction. But before handing over the session to Sir, it's my privilege to introduce Dr. Pippin, a renowned cardiologist and electrophysiologist based in Singapore, as the guest speaker for today's webinar. In 2016, Dr. Pippin established Asia's first pulmonary embolism response team at the National University Heart Center, Singapore. And he has led innovations such as ultrasound-assisted thrombolysis and large bore suction thrombectomy for pulmonary embolism. His groundbreaking work has resulted in patient surviving rates exceeding 94% in early interventions, and he has also published 130 peer-reviewed articles in various international journals. Since launch of Inari device in Singapore, Dr. Pippin has led the therapy and treated over 70 PE patients with the FlowTriever system. We are honored to have him here with us today, and I extend a warm welcome to him. With that, I would now like to invite our respected chairperson, Dr. D.S. Chadda, sir, to kindly take over and lead us through the session. Over to you, sir.
Thank you. Thank you so much. It's indeed an honor to have Dr. Pippin here, and we have a very august panel and speakers. They do not need any introduction. We are here to learn from Dr. Pippin about a disorder which is very commonly encountered, but very rarely diagnosed in time. It's a disorder where our experience is essentially confined to using oral anticoagulants or antithrombins. Maybe in certain cases who are hemodynamically unstable, we go on and use thrombolytic therapy. The eventual outcomes, I don't think, are well monitored in our setup because we don't follow up these patients too well, and we really don't know much about the mortality in terms of the life history of the disease. There's been evolution in this sector. There is something which is more than what we have been doing, and we are at the juncture of changing our approach to these patients. And what better person than Dr. Pippin, who's going to tell us as to how we can manage these patients well, who are kind of diagnosed, with difficulty and managed not so well as they have to be managed. So the flow of events is going to be, flow for this evening is going to be, we'll have a lecture from Dr. Pippin. I would request all the panelists and the speakers to actively participate in this. And thereafter, we'll have some case presentations, and we'll keep discussing the findings as we go on. I invite everybody who's present in the panel and the speakers to actively participate in this. May I invite Dr. Pippin to share the screen and start his talk, please. Welcome, Dr. Pippin.
Dr. Chadda, thank you very much for the kind introduction and as well as the kind words. So looking very much forward to learning from all my colleagues in India as well. And thank you to Veiva and Inari for putting us all together. So we're going to talk about PE management, and I hope everyone can see my slides. So we are facing an increasing burden of pulmonary embolism, not just all over Asia Pacific, and we are seeing increasing number of cases because we have an aging population, we have more patients undergoing surgery, and our oncology colleagues are doing great in terms of increasing survival from cancer. There's always this belief in the past when I talk to some, particularly orthopedic surgeons, and they tell me that the Asian patients don't clot. Well, we do clot because I've found a whole ton of people with DVT and PE. Can I just check on the live attendee view? They can see my slides. Great. Okay. So this is actually a very common disease. It's the third most common cause of cardiovascular death. But really, as you can see from this picture here, often the PE patient doesn't receive any clinical ownership. They are stuck between various specialty groups. It's also a time-sensitive condition. And so just like stroke and just like a MI, the longer you delay, the patients are at greater risk of developing right ventricular failure. That's how they die. And I'll show you in a slide later on. And more importantly, unlike having a stroke or having a heart attack, actually, patients are scattered throughout our health system, and largely they're managed by colleagues who don't really have a lot of PE expertise. And we have to recognize that most hospitals in Asia Pacific, even till today, lack a systematic approach or hospital level guidelines to manage these patients. So I started to form a PERT in 2014, and actually this figure here pretty much summarizes what we were doing for the first 4 years. So we made a diagnosis of PE, and basically if you had a low risk PE, you were start on anticoagulation, you were discharged early, that's fine, we still do the same thing now. If you had intermediate risk PE, you would get anticoagulation, and we would monitor you. Probably up from 7 to 10 days, depending on how comfortable the physician managing you would send you home. And then if you had high risk PE, then you would get thrombolysis if there was no contraindications. Otherwise, we get everyone together and we consider doing some kind of surgeries, ECMO, and for a little while we were experimenting with using angiojet. Now, I want to give you a insight into what the Singapore PE patient looks like. And this was our first paper that we put together, really patients presenting with PE to our institution over a 4-year period between 2013 to 2016. What we found among these patients was that 63% of them were inpatients at the time of diagnosis. What that tells you is that if you're going to set up a PE service and you were camped in front of the emergency department, you would miss 63% of your referrals. A quarter of them had surgery in the last 30 days. So most of these patients were still looked after by surgical teams. 29% of them had active cancer. So these were coming from the oncologist. And what was a little bit surprising to us was that compared to what we see in European or American series, 80% of our patients had intermediate risk PE. 10% had high risk, and roughly 10% had low risk. So we have a much higher proportion of patients with intermediate risk PEs compared to what is described in the literature. Now, so we put in the PERT team in 2014, and we looked at whether after 2 years of having the PERT team, we made any difference. And sadly, we found that we didn't, although we had a PERT team put in, we didn't really manage to improve survival. So overall survival remains statistically the same pre and post PERT. In the high risk population, roughly 30% of patients were dying before discharge. And even in the intermediate risk patients, only about 90% of patients were surviving to discharge. So we were all very disappointed when we looked at the results, because we thought, all this effort in getting organized, getting together, and we kind of brainstormed and thought about what were the things that was causing this. So maybe it was because from the time of diagnosis to receiving thrombolysis, that decision process still took 3 hours, because probably it's not an easy decision to make, right? Maybe referrals were delayed. But I think the main problem was that until 2019, we reserved interventions only for the highest risk patients, and usually they've either failed or have absolute contraindications to systemic thrombolysis. Systemic thrombolysis remained the mainstay of reperfusion treatment, largely because there was a lack of dedicated equipment designed for PE. So we kind of thought about this, and we felt that we had to change the way that we treat PE. So in 2019, we started experimenting with catheter-directed thrombolysis. We used small caliber aspiration catheter. And in 2021, we finally had access to large bore suction thrombectomy, which is the FlowTriever system. And we also introduced a 24/7 PE on-call service, which was really piggyback on top of the primary PCI service for ST elevation myocardial infarction. While we were disappointed, we were actually surprised also to find that the rest of the world wasn't doing any much better. So when we looked at all-cause mortality at 30 days in PE patients, this was the 11.5% we had from our PERT survey. MGH published results roughly around the same time of 11.8. The iCooper registry from 1999 was 12.5. And even the PERT registry from 2021 showed a all-cause mortality of 10%. If you think about it, 1 in 10 PE patient will die within 30 days. That's a shockingly high rate for a condition that most people don't even think much about, right? And if you look at by risk level, mortality remains at about 6 to 15% in submassive intermediate risk patients, and as high as 25 to 50% in massive PE patients. So it all comes down to, I think, the fact that we've been treating them the wrong way. So this is conventional therapy over the past 20 years. So you diagnose someone with a PE and you give them blood thinners, and then you keep having this decision loop, which I've tried to summarize here. So every morning you see the patient doing a ward round and you say, is the patient worsening or at an imminent risk of getting a cardiac arrest? If it's no, great, you keep them for another day. If it's yes, then you give them thrombolysis at the risk of a 11.5% risk of major bleeding and 2.0 risk of a bleeding stroke. This is from the PYTHO study, right? And as a result of this, the ESC says, please do not routinely use systemic thrombolysis for patients who are not suffering from shock or hypotension. It's a class 3 indication. So if you're stuck doing this, then there will be a few unresolved questions. How long do we monitor this patient that's stuck in this loop for? We don't know. When's the patient out of danger? How long does it take for the blood clot to resolve? Weeks. And when will the strain RV ever recover? Okay. Now, I think there's a better way of treating PE. So what if we change our treatment algorithm? And so the aim now is going to be to remove the underlying blood clots in the safest, fastest way possible to allow patients to recover fully and discharge early, right? So you have the same starting point, patients diagnosed with PE, we still give them anticoagulation. In the ward round, you have a think, what's the risk of a patient having a cardiac arrest or getting worse? If it's very low, as in our low-risk patients, you send them home with oral anticoagulation. Those who have higher than low risk of PE, progression or decompensation, then just remove the blood clots in the lung. And we can now safely achieve this with less than 1% risk of major bleeding. Most patients can go home within 48 hours. And as I'll show you shortly, you can greatly improve their 30-day mortality. And, you know, for those of us who work in the cardiovascular field, this is kind of not a unfamiliar pattern. We started with myocardial infarction and stroke. In these conditions, we used to give anticoagulation only. Then we went to lytics. And then eventually now mechanical reperfusion therapy is basically the gold standard. So why should it be any different for the leg or the lung, right? And I think we're at the cusp of this evolution here. So in late 2021, we started doing this, and you know, everyone likes to see clots out, and I can show you lots of pictures. The technology even allows us to remove very, very distal clot. As you can see from this picture here, you can actually figure out there's a blood clot cast of the distal pulmonary arteries. With suction procedures, you don't need to go to the extreme of the artery to get the clot out. If you suck proximally, most of the clot will come out. And so this is what we saw in our first 40 patients. We saw that whenever we applied this very helpful technology to them, we saw a mean PA pressure reduction of 23%. The RV-LV ratio, which is the size of RV overload, came down by 20%. The heart rate came down by 9 beats per minute. Procedural time for our first 40 cases in Singapore took about 2 hours. This was the profile mix of patients. Most of the patients kind of had intermediate risk PE, but 42% had contraindications to thrombolysis. And in fact, 10% of them had already received thrombolysis and didn't respond. So that really emboldened us to kind of change the way that we treat our PE patients. And from 2021 onwards, this is how I treat PE in our institutions. If you have low risk, you have anticoagulation and early discharge. If you are intermediate risk, you are given anticoagulation and the option to proceed with mechanical thrombectomy. And I will tell you that in excess of 90% of patients who have been offered, they will accept mechanical thrombectomy because they want to get better sooner. For patients who are peri-arrest or have ongoing CPR, they will be stabilized with thrombolysis and ECMO. Getting thrombolysis or ECMO doesn't preclude them from getting thrombectomy. So even once they're on to ECMO, most patients will still go on to have a thrombectomy. And for those high-risk patients who are stable enough to go to the lab, they will receive mechanical thrombectomy. And so we've just published this data in thrombosis research a couple of weeks ago. And so this was where we are in 2016. Our mortality at 30-day was about 9.8% for the intermediate risk group. This is consistent with what the PERT database saw in the US. And after our first 100 FlowTriever cases, we've halved that mortality to 4.3%. Now, of course, we can do better. There's data from the FLASH registry and the recent Peerless RCT trials. But remember, in these registry or randomized control trial, patients were selected. So getting a prior cardiac arrest and various things would preclude you from being admitted into these registries or RCT. So our data represent really an all-comer real-world data. And we are very, very happy to see the halving of this 30-day mortality. From a hospital administration point of view, if the CEO wants to know why we're doing this, you can comfortably tell him that, look, once you have a PERT, we reduce ICU length of stay. And once you start doing mechanical thrombectomy, most patients actually don't even require ICU. Okay, so, and therefore you convert something that's potentially life-threatening and in fact life-ending in 10% of patients, and you convert this to a very stable routine care, and most people get to go home. So I'm going to go through 3 cases in the remaining time just to kind of pick up some learning points that I thought would be quite helpful for those of you who are perhaps just embarking on this journey of PE intervention. So the first patient is a 70-year-old lady. She's known hypertensive on atenolol. She came back from a trip to Malaysia and she got breathless while she was there. She came to our ED, there were ECG changes, the troponin was positive, D-dimer and BNP were elevated. Blood pressure didn't look so bad, 104 systolic, heart rate of 66. Remember, she's on a beta blocker, and she was able to saturate 100% O2 on 2 liters of oxygen only. Her ultrasound of her legs done portably in the A&E showed bilateral below knee DVT. So I think most of us would suspect PE in such a patient, and this was the result of a CTPA. You can see that there are clots bilaterally, both in the left and right main pulmonary artery. And for those of you, this image for me on the right is actually the most important thing in the CTPA. For me, you don't need an echo, even as a cardiologist, to tell you whether or not the patient has RV overload. Just measure the size of the right ventricle and the left ventricle on the CT. That's all you need. You don't need an echo to do this. And you can see clearly that the right ventricle is grossly larger than the left ventricle, and that's never normal. So we do a left pulmonary thrombectomy on her, and this is the angiogram after. So I never take any pictures before doing suction because I've got the CTPA. I know where the clots are. I don't need to shove them more distally. For those of you who are not familiar looking at this, what I appreciate from this angiogram is that there is adequate perfusion in all 3 lobes of the left lung. And more importantly, if you look in the late phase, you should be able to see very brisk left pulmonary vein return. So that means that the contrasts have gone all the way in through all the arteries and come back into the heart using the pulmonary veins. I'm an electrophysiologist, so it's quite easy for me to spot pulmonary veins. There's 2 of them in this lady here. Same thing on the right. I do 2 runs on the right. I remove a substantial amount of clot, and then I do a PA angiogram, and this is what the picture is. I'll let it run one more time. And what I saw on this picture was that there is residual clot in the truncus arteriosus, even though the pulmonary vessels are now quite well filled, and there's also brisk pulmonary vein return. So nonetheless, I think the clots in the right upper pulmonary artery or the truncus arteriosus remains quite substantial. So if you want to, and now that the patient is very stable, we've done the left, we're just tidying up the right, you are able to access even the smaller segmental arteries, and here we're using a GR4 catheter. We've wired the truncus, and we're able to aspirate the clot out. So this is the clotogram. Everybody likes to look at this. But for me, what's more important is this. So her PA pressure falls from 55/20 to 32/18. Her post-procedural blood pressure is 145. Remember, she went into the procedure with a blood pressure of 104. That's a 40 millimeters mercury difference. So I would argue that she was actually in shock going into the procedure. Her sets are now 98% on 2 liters oxygen. It took us an hour to do this. Fluoroscopic time was 16 minutes, and we used 16 mils of contrast. If you look on echo, her pre and post thrombectomy RV-LV ratio is gone from 1.2, so the RV was much bigger than the left, to now the normal ratio, where the RV is only 60% of the width of the left ventricle. So you've managed to reverse the RV strain on this patient. Post-procedure, no groin complications. She didn't feel breathless anymore, and we sent her home on a day 2 on the Pixaban. So there's no, and she's been followed up for more than 12 months, and she's got no recurrence of VTE. So for me, it's a straightforward case, but I want to remind everyone in the audience, in your career till today, how often have you safely discharged a patient with symptomatic bilateral submassive PE the next day after admission? Think about it, right? Now in my unit, it's become routine. In fact, people get surprised when these PE patients stay for more than 2 days. So this is how much we have changed the landscape with this technology. Case number 2 is, I'm going to start with some ECGs, and I appreciate not everyone in the audience are cardiologists, so I'll talk you through the ECG. So apologies to the cardiologists who think that I'm baby talking to you. This is a patient who at 6 o'clock has this ECG. This patient, I will tell you the profile in a bit, has a blood pressure of 130/80, saturation is 100% on 2 liters of oxygen. And then you can see here very quickly, about 1 minute later, that he starts developing ST elevation in the inferior leads. He's actually having a inferior myocardial infarction. And because this PE patient's RV pressure is now exceeding his right coronary artery perfusion pressure, so he's getting ischemic. Now, the right coronary artery also supplies the sinus node. So at this point in time, he decides to go bradycardic because the sinus node is now ischemic. And this is at 6:02. And then in the next slide, you will see that at 6:03, he starts developing a broadening of the QRS. Now the right bundle fails, and he starts having VT. And then a minute later, this VT accelerates, and he develops polymorphic VT. 4 minutes after that, when his blood pressure was 180, he now is in VF, and another minute later, he is asystolic. So I've just shown you the ECG of someone with a intermediate risk PE dying from their PE. And I will tell you that the profile of this patient is a 38-year-old male who is day 2 post-knee surgery. He developed breathlessness after lunch. He was diagnosed with a submassive PE. Remember, blood pressure was 130. We can't give him thrombolysis because he's just had surgery, and he actually wasn't hypotensive. He was started on heparin. We had to clear the Cath lab's elective work. And then so he was going onto the table at 6 p.m. We were basically cleaning him. We was getting ready for access when all this happened. And so 40 minutes later, his blood pressure is back to 120/80 after bilateral thrombectomy, and he was discharged 2 days later. Now, I'm going to show you data that's just been published in one of the large cardiology journals. And this is data that really comes from the PERT registry in the US. So this is a collection of PERTs in the US, and they pull their data together. And we're going to look at specifically among this more than 5,790 patients with PE, the high-risk PE population, right? And so here they've divided the high-risk PE populations into two groups. One who does not have hemodynamic collapse, 1,245 of them, and the other group who are high-risk PE, hypotensive by definition, but also have had a hemodynamic collapse. What you can see here, and I ask you to focus at the bottom here, is that the inpatient mortality, if you are intermediate risk, is 3.7. If you're high risk, is 20.6, but not all high risk is the same, because if you don't have a collapse, your high risk in hospital mortality is 17.2, but once you've developed a cardiac arrest or decompensated, your in hospital mortality becomes 42.1. So if you think about a second patient who has intermediate PE, who suddenly collapsed just before he's about to get his thrombectomy, his mortality has increased 10 times just by developing that collapse, okay? So think about it. If you allow your intermediate risk PE patient to decompensate, their in-hospital mortality goes up by tenfold, okay? And I think the learning point from this case is that no matter what algorithm you use, no matter which expert you talk to in the world, we are all terrible at predicting which patient will decompensate. And we know that outcomes are so much more worse when stable patients deteriorate. So for me, the sweet spot of PE intervention has to be in the intermediate risk patients, because these are the stable patients who can go home today. And if you don't act on them, some of them will develop catastrophic decompensation, and you will lose that window to get them home. And this has been shown consistently in other studies. This is the Prague out-of-hospital cardiac arrest study, of which out of 256 patients, 24 of them had PE. You will see that the 180-day neuro recovery rate, so people who had a functioning brain at 6 months, was 2 out of 24 for PE patients and 28.4% for non-PE patients, right? And this is the same data you get consistently from all these out-of-hospital cardiac arrests. And which, for me, it begs the question, when patients collapse from their PE, we instinctively do CPR. But how helpful is it when we keep recirculating this hypoxemic blood? What does it do for the brain? Probably not very much. So it takes me to my last case, and this is someone who clearly has something very bad going on with his brain. This case number 3 is a 70-year-old gentleman. He had a mechanical fall with a head injury. He's been having frequent headaches for about 6 weeks now. And separately, about 2 weeks after his fall, he developed breathlessness on exertion. He's usually a regular runner. Nothing much in his past medical history, no family history of VTE. Blood pressure is quite good, pulse is 66, chest x-ray is normal, and the BMP is elevated. So this is his brain imaging. There are radiologists in the field, so I'm not going to embarrass myself, but he has bilateral subdural hematoma, more on the right than the left. And this is his CT pulmonary angiogram. He has bilateral PE, as you can see here and here. His coronary arteries are normal, his RV is dilated, his PASP on echo is 45, and on ultrasound, he has bilateral below-knee DVT. So we have a patient with symptomatic, intermediate high-risk PE, and bilateral subdural hematoma. So what do you want to do for this patient? You can tell the patient, I'm really sorry, you're bleeding and clotting at the same time, so I'm going to leave you untreated because you're too high risk for anything. We can give anticoagulation like we always used to give and hope that the subdural doesn't get worse. And then if you survive 3 to 6 months, we'll operate on your brain. Or we could just remove the blood clot in your lungs and just get on with needed neurosurgery. So this was pulmonary thrombectomy, and we did this with much less heparin than we normally give. We gave 1,000 units every 10 minutes. So we finished the procedure in 30 minutes. This was his parameters before. So blood pressure of 99/56 went up to 119/75. Oxygen requirements went down. The pulmonary artery systolic pressure went from 40 to 31. We also stuck in an IVC filter because he has this bilateral below knee DVT, and this was the clot that came out from his lung. And so 6 hours after thrombectomy, the very nervous neurosurgeon went to repeat his cerebral imaging, and his subdural remains the same size. And at 3 days post-thrombectomy, it remained the same size still. So first day, we didn't give any heparin, we didn't give any anticoagulation. We did the same on day 2. Day 3, he had a craniectomy and a subdural drainage. Before he went for his neurosurgery, the anesthetist insisted on a repeat CT pulmonary angiogram, and you can see here that the pulmonary trunks are now clean. He was started on apixaban on day 7, so 4 days after his neurosurgery at half dose. At 3 months, he was free from PE recurrence. The IVC filter was removed. He still had some residual clot, so we increased his apixaban to the usual 5 milligram BD. And the learning point from me for this case actually was that actually FlowTriever just makes it so much simpler to manage our patients. And for all types of PE patients, it provides the avenue for us to manage them safely, especially those at high risk of bleeding complication. So in conclusions, I urge everyone to treat PE with the same urgency as you would for a heart attack or stroke. You know, get organized, get skilled in delivering such kind of expedient, low-risk reperfusion therapy. We now can do this very effectively with the FlowTriever system. We prevent our patients from hemodynamically deteriorating, from having a cardiac arrest. They can go home the next day, and the procedural risk is really quite minimal. As I've shown you in our registry, 90% of our patients are either intermediate or high risk, and therefore they are eligible for thrombectomy. And I believe with the data coming up over the next few years, pulmonary thrombectomy is going to become the gold standard of care for PE management, just like how we manage strokes and heart attacks today. With that, I thank you very much for everyone's attention.
Thank you, Dr. Pippin. Your talk was very lucid, and it was kind of an eye-opener. I started the session by saying that we are definitely missing out on lots, and I think it's kind of scary, the amount of clinical load we are missing out, and a lot of people which are slipping out of our practice. So I have here my lot of senior colleagues who are there in the panel. So I invite them for the comment. Dr. Bali, Dr. Raghu, if you all would actively engage and share your experience. Dr. Bali, please.
I think excellent talk, and it just tells us how many pulmonary embolism we are missing. And the problem I see is that the awareness is not that extensive as should be. And secondly, as very rightly pointed out, we see few cases. They get scattered all over the specialists. But by this FlowTriever, a lot of these patients can be managed in the shortest possible time. Two problems remain. One is, I think the blood loss still is an issue during the procedure. And second is cost would be a factor, because when we started primary angioplasty about 20 years ago, that factor was there. And convincing patients to undertake such a procedure would take some time. And but now we have that standardized. Patients understand primary angioplasty is the treatment to go to. Stroke intervention is the treatment to go to. So cost is not that important a factor. But here we would need to convince patients that we are looking to not only to save life, but also to improve their effort tolerance and quality of life by taking care of these moderate or larger size of pulmonary embolism. So it's a very great intervention, very satisfying intervention. And I think it is, as very rightly pointed out, would become the standard of care in coming months to years.
I completely agree, Dr. Bali. I think you know, this is why we need forums like this, because you are actually, you know, leaders in PE advocacy in your regions, right? And we not only need to talk to people who are convinced like us, but all your colleagues who don't think about this, right? Because I mean, I spent the first part of the chit chat saying that I've met more people in my hospital as a result of getting involved in PE. I've met people who I've never spoken or even knew worked in the same hospital. The gynecologist, the oncologist, the orthopedic surgeon, the geriatrician. I used to work in my own silo until I started doing PE, and I actually met so many more friends in my hospital. So this is the message that needs to get out to them. Yes, it will take time. I mean, I started this in 2014. This is my 11th year of doing PE. So I've kind of put 11 years of work into 20 minutes, right? And the journey has just started for most of you, and I'm sure you will do it much more efficiently and faster than I am doing.
Anyone else with any comments?
Yeah, Dr. Dr. Chada, I will make a comment. This is Dr. Raghu. Am I audible, sir?
Yes, absolutely.
Yeah. Okay. So, Dr. Pipin had provided a very interesting scope of where he is getting the cases from. About a third of them were coming from the oncological colleagues, and a third were coming from the orthopedic colleagues. Actually, what's happening is this is exactly reflecting my practice also. Previously, I had one of my partners in my business was an orthopedician and a spine surgeon. So I used to do almost in about 3 years, I did 35 PE interventions. But the moment I'm no more associated, suddenly the numbers drop down. So I think the partnerships, because performing the procedure is one part, but beyond that, to make them aware of the procedure and maintaining the case flow needs a great partnership with many other specialists. I think that is a very important message, because it's not enough that Inari is a catheter which is available, but we need the partnership to channelize the patients. I think that is where, like normally as cardiologists, we tend to get the acute MI patient walks into us because they know that where the patient knows where they need to go. But here it's a very tough field. Like I collaborate with the pulmonologist right now, but I get only 15% of the patients. But I think I'm losing 85% of the patients. I think pulmonologist is a limited thing, but when we collaborate with our surgical colleagues and oncological colleagues, I think that's where we can maintain a flow of work. That's one comment I wanted to make. And then I wanted to say that with the availability of the Inari, I think the bleeding is not a very major issue, because we can, there is a filter syringe, we can give it back to the patient, not much of a bleeding, this one. And when we use the other companies also, we used to use a what we call as the flow cell saver, which is available in the surgical colleagues with the transplant team. So using that, we used to infuse back the blood, whatever blood we lost, and give it back. If you do not plan for this blood loss, the patient is hypotensive, you remove 100 ml blood, the patient collapses. So it's very important that you need to understand the hemodynamics and foresee that if you remove the blood, the patient will collapse. I think that's a very important thing we all need to understand. Thank you.
For me, I think more important, I mean, what you said is amazing, which is absolutely correct, that I mentioned in my opening remark also, that we are not diagnosing enough because we have not teamed up. The environment has to be sensitized, and we need to sensitize people. But I don't think in our setup, in our country, people have come forward and have advocated kind of mechanical intervention for pulmonary embolism. We need to sensitize the amount of difference it does to the mortality, the amount of difference it does to the morbidity, and the ease it brings about, and ease in terms of bringing the patient out of woods and kind of truncating his hospital stay, ICU stay. And it is, this therapy kind of is revolutionary. Yes, it comes at a cost, but I know India is a developing nation. Cost is a very important factor. But I personally feel that we have been doing certain things with our other patients to save costs. The same can apply to this system as well. But I'm told that the blood loss with this is definitely much lesser than the penumbra system, which has been there with us for long. The flow rates which these catheters, because these are large catheters which they generate, is much higher, so they suck much better. And in terms of cost in the country, this system is definitely competitive with the Penumbra system. So I feel that we need to sensitize the environment and make people aware that moving forward, and some amazing cases Dr. Pippin showed, I mean, the complete spectrum which you get to see from a patient who has a contraindication to thrombolytic therapy to a patient who's young and who's kind of going down. So I mean, it's phenomenal.
Dr. Chedda, I wanted to ask Dr. Pippin one question. The
Yeah,
major,
please.
major challenge what nowadays I face is differentiation between a acute PE from a CTEF, because I will try to learn. I will learn from Dr. Pippin, and possibly after that, I will, if possible, I will make some comments if what I have observed also. Please, Dr. Pippin.
I think we can't hear you, Dr. Pippin. Right, I think there's some connectivity issues. So what we can do while
But Cheda, can I just put in a comment?
please,
Like, this is Dr.
please.
Sumanto from Calcutta. So, what the one issue is definitely getting the diagnosis. But what we commonly, like in my setting, what I've seen is we also see a lot of oncological patients and some orthopedic post-surgical patients having this, DPs, which is mostly submassive. If it's massive, it becomes pretty straightforward. We either go for thrombolytic therapy or thrombectomy, depending on what the patient. But it becomes more of a challenge in the submassive P, whether to continue anticoagulation versus go for they do not form an indication for thrombolysis. So they are probably the best candidates for thrombectomy. Now, still now, what I feel is that it is not clear amongst us also that there is a definite mortality benefit or what the benefits are, which Dr. Pippin showed that yes, there is. And the other part, as we were comparing, or as Dr. Pippin was also comparing, that yes, reperfusion, mechanical reperfusion therapy, it is the gold standard in coronaries, now in stroke, so probably it will be. But just to get an idea of, like, with regards to the economic constraints, so I don't know what it costs, but on an average, we can do a primary angioplasty between 2.5 lakhs in Indian rupees. Similarly, with a thrombectomy in stroke, around 2.5 to 3 lakhs. Whereas if I have to use either which is a Penumbra or an Inari, in these settings of submassive PE, it would cost more than 10 lakhs. So I think that does make a bit of difference with that your mortality benefit or your immediate mortality benefit in submassive P is not that well proven. And then with the expenditure that it comes, it becomes really a difficult situation in countries like us, where most of the people are paying out of their pocket, and particularly in oncological patients where they're already been spending lots and lots of money for their ongoing oncological treatment, or a patient who has had recently a surgery from an orthopedic, like a replacement surgery. So I think with regards to the industry, they should look upon that how it could be bought into a more, economically into a place that it can be given more widespread. Because until and unless we don't do it widespread, we don't see that the results are good and there is a definite benefit. It is difficult to, if we do maybe out of
We get
10
your point, Dr.
submassive.
Sumanto. We get your point. You're talking about the cost, and I mentioned that, and we can have a discussion on that. What we do that keeping the time in mind. Dr. Pickling, you should comment that. Otherwise, I'll invite the case presenter so that we can have
Yeah,
that.
no,
There
sorry.
was a
Can you hear
question
me
that.
now? Can you hear me now?
Yes, we can hear you. We can hear you.
So the question about the acute PE and the CTEPH. So there are three buckets of patients, I think. There's the acute PE, there's obviously the classic CTEPH, but there are also people with acute on chronic PE, right? And that's where it gets a little bit difficult. And in short, basically the best way of distinguishing them is going to be your clinical history. You need to look for this patient who has this acute onset of symptoms and acute deterioration, right? So that's one clue. that I suddenly got breathless a week ago. So that really is something to help you with that. But even that is not perfect. I accept that. The other thing is that on echo, if you see very high pulmonary pressures, if you see a pulmonary artery systolic pressure of 70, 80 at presentation,
Chronic.
it is likely that it is chronic. There's a level of chronicity to it. I won't say that there isn't an QP, but there's an element of chronicity to it. And another third thing is that if your radiologist is very good, they do the CT and say, hey, apart from the QPE, I can see that some buds, there are some chronic occlusions, there are some web-like occlusions that look like CTEPH, right? Then that's another clue that helps you. And then finally, I think the CTEPH patients are often partially compensated. So they look better than the amount of clot that you see. So you see this horrible looking pulmonary angiogram, and yet they're sitting there, they're having their tea with the saturations of 89%. You're pretty sure there's some level of chronicity to it. So those are the clues that I look for.
Perfect. Perfect. So with this, we go on to the case presentation. I invite Dr. Barinder to present or share his case with us. Dr. Barinder,
Thank
if
you,
will,
Dr.
please.
Chadha. Just one quick question to Dr. Pippin,
Yeah,
which no
please.
one asked. It's regarding the technicality. I've seen your images in which you have used T24, and then you have used the curve catheter on the left side, inside the bigger catheter smaller. So tell me how many percentage you have to take a T16 or a T20 with T24, because then it changes the entire scenario in Indian setup, because we can't come up with two devices at a time. We don't have a package system here. So
Okay, right. So we have a package system in Singapore. So that's one of the reasons why I use it. But I think for the curve catheter, I use it about 50% of the time for the left pulmonary artery, just to get over that angle that you need to go over the left. On the right side, to use a smaller catheter like what I showed you earlier, I think less than 10% of cases. Most of the time, you can get everything out with T24. I think if you told me that you had to pay extra for each of these catheters, I probably will struggle a little bit longer with each catheter. So again, the pricing does change practice. So again, we work on a package price in Singapore. That's why we are a little bit more liberated to take extra pieces. But you don't need it most of the time.
Yeah, thanks. So I'll start with my case. So hello everyone. I'll be sharing a real world experience with Inari Flow Driver. The device came after our experience with Flash 16. So the number of cases which we have done with this system is comparatively less, but I'll be sharing, this was the case just done yesterday. So a 71 years old female, we get a call from ICU that patient has severe thrombocytopenia. There are multiple hematomas in the leg. We cannot anticoagulate, on inotrop, and all the signs of intermediate high risk. PA pressures were basically 70. So finally, we decided that we'll take her. The history was deceptive. As Dr. Pippin told, the son was not able to give exactly the history. So the history was 10 days old. And then he gave a history of fracture of the femur, and she had similar episode 3 months ago. So we were quite sure that this will be acute or chronic, but we took her in the view of all the parameters of intermediate high risk. So the experience with the Inari system is like a wonderful sheath. So we went with a T24 system, which is readily available and kept in the hospital. We usually do a pre-close. I mean, you can see there is a ProGlide suture. You can put a figure of 8 depending on your practice. So wonderful sheath placed in. This is what the system looks like. So it's basically a well hydrophilic, long, I would say, perfectly made sheath with a great valve and a side port, which is really big. And the special syringes which come for those who have not used. And then that's the cell saver, so, or the blood saver, whatever you want to say, or flow saver. And so everything is kept ready. And once the access is taken, it's a really hydrophilic system, as I told, really slippery on the hand. So once it's prepped and draped, you have already parked your wire in the right pulmonary artery. So you go slowly. Patient had bilateral popliteal DVT. but both CFE, iliac veins, and IVC was pretty clear. So once you go in, you can see once you reach the region, how smoothly the system tracks. Even we were wondering, like being a 24 French system, how, but over the dilator, it tracks very easily. You make a good loop of the wire, and then you can see with keeping the dilator over the wire, the system goes, and then you just jam it against the thrombus. And I'll be showing quickly. So that's how it is. So you can see the syringe has a great negative suction. There is a Woods effect. So blood with the clot comes out, and then this blood can be actually placed back through the contralateral sheath, or it also goes through the same 24 sheath if you want to use the ipsilateral sheath. So once the clot is separated with this system, the blood can be returned back. That's another advantage. So you can instill the blood back into the body. So the device is a great large bore device, clears up good amount of thrombus, and as Dr. Bipin has told, the imaging criteria is not the criteria to call it a great opening up. The patient should improve on table, and safely as much as you can remove, definitely you should go ahead and remove it. The another difference which we saw with the penumbra and these devices, you have to keep the wire throughout. In the penumbra you can't. If there are large chunk of clots, then the Inari 24 being a bigger bore is little helpful. So this was the thrombus or the embolus, which can be removed, subacute, chronic, and sometimes if you are lucky, you would get a picture perfect as well. The advantage which we saw over the other device was the no capital equipment. Basically, you don't need a suction machine because it's a manual suction with a specially designed syringe. Definitely a lytic-free approach, and there is a mechanism to save blood. So just to show this, I mean, this is one way of removing it, and then you have discs which are available, or the aspiration or the Trevor discs, which can be used for subacute. We haven't used that yet, but I would love if Dr. Pipin can definitely step in and tell us his experience, how often he used this discs and how safe they are. So till date, we haven't used it, but we have used the aspiration catheter. Now, coming to the last slide, I completely agree with Dr. Pipin that it happened with MI, that everybody is treating primary with stenting. Same has happened in last decade for stroke. Now MT is the treatment of choice, and this, I hope this is going to happen with pulmonary embolism. Now we have come down even with the intermediate low risk patients we are treating with mechanical thrombectomy, and the datas and the RCTs will be coming soon. Thank you.
Thank you, Virender. That was a very nicely done case. So what we do is we'll finish off all the cases and keep the discussion at the end of the cases. So that, can I invite Dr. John Joes to share his case, please?
Thank you. Unfortunately, I don't see the share screen on my Zoom window.
No, you've not shared it. You share it, I'll let you know if you shared. Okay, fine. Go ahead.
No,
Share button is not there?
Yeah, it's not there.
So if you can click once on the tab and see if it is there, or else what we do is you re-log in, and I'll in the meantime invite Ajit if he's there. Ajit, are you there? Ajit Pillai was supposed to present, no?
Sir, Dr. Ajit Pillai has some emergency, so he is not available right now.
Okay. So Vinay,
in place of Dr. Purohit, sir, Dr. Vinay is there. Dr.
That's
Vinay is
I'm calling for
actually
Vinay only. I'm calling for Vinay only.
Yes, sir. Yes.
So Vinay, if you can share the screen while John, you can reload this thing. You'll definitely get the share button.
I'll re-log in soon. Yeah.
All right, fine. Vinay, if you can share the screen. Vinay, you kept yourself mute. If you can unmute yourself.
That's what I said.
Yeah.
No,
Am I audible, sir?
Yes, you're audible.
I'm Dr. Vinay, sir. I'm associate of Dr. Purohit. Unfortunately, he has some emergency and he left. And he made this presentation and he asked me to share with you.
So you please share your presentation with us.
Are you able to see?
No, it has not come as yet. All right. While you're attempting to share any points from the panelists, Deepak, Dr. Tarun, Dr. Makle, you have to unmute yourself, Dr. Makle.
Yeah, good evening. So as Dr. Virendra highlighted that, because what we would require to hear from Dr. Pippin is the technical challenges which he faces, because, once we have these patients who have significantly dilated RV, those were the ones we were facing a lot of problem negotiating the catheter from the femoral route. So in how many cases, Dr. Pippin, you have tried to come from the jugular route as well?
So I do jugular cases, probably less than, I think in the last 100, I've done 5 jugular cases. And of them, 4 of them was because there was an ECMO cannula at the bottom. So I don't do the jugular cases often. I think the trick to the very big RVs is that, one, your wire position. So get a distal sort of medial position with a very stiff wire to give you that traction. Right. I think that's my number 1 trick, I think.
Okay. Thank you.
Hello,
Thank
sir.
you.
Am I visible?
Yes, your slides are visible, Vinay. You can go ahead.
Sir, thank you very much. We had a female of 34-year-old with a hemorrhage of diabetes and bronchial asthma. He had the history of idiopathic thrombocytopenic purpura with very low platelet level. She had sudden onset of breathlessness with giddiness since 1 day. And on arrival, her vitals are like this. He had tachycardia with hypotension with saturation is 80% on room air. And she is requiring NIV for maintaining her oxygen level. So we have done one 2D echo. 2D echo is showing severe pulmonary artery hypertension with moderate PR with RV dysfunction. By seeing these values, it looks more alert and more harm to the patient. So the platelet count was around 70,000 and D-dimers were pretty high. So we counseled the family regarding the options we can give. But the platelets are very low. He comes under high bleeding in this category. So we gave the first choice of mechanical thrombectomy. And CT pulmonary angiogram revealed only a large right main pulmonary artery thrombus. On left side, it is only segmental and subsegmental thrombus. So we went with the procedure, explaining them. We crossed the RVOT and LV using this balloon tip catheter, and then exchanged the wire, and then we have done one angiogram on the right side. You can see on the right main pulmonary artery there is a hazy filling defect which is sitting, which is causing significant flow limitation on the right side. So we park the lung request wire on the right side, over which we track the Inari catheter. The Inari catheter is 24 French catheter. We track with the dilator slowly into the right main pulmonary trunk. We went there, we have done almost 5 to 6 aspirations, and auto transfusion of the blood was done. So after that, the result was like this. Then we entered into the segmental level. So right upper lobe, we entered with the JR through the sheath, and we checked it. So we have done aspiration on the right upper lobe pulmonary artery also. So almost 5 to 6 sessions was done on the right side. After that, this is the result. So it looks very good on the right side. There is, even though there is small thrombus, you can see in the right upper pulmonary artery, right upper lobar pulmonary artery, and others are flowing well. And there is good blush on the periphery of the pulmonary artery or pulmonary lung also. So on the left side, we checked with the injection, but it is showing that good blush on the periphery. There is no main thrombus in the left main pulmonary artery. So we left it. So after the procedure, this is the thing we aspirated. So it is there on the right main pulmonary artery and including the right upper and middle and lower pulmonary arteries. So Inari catheter is useful in treating the patients with the thrombus in the right main pulmonary artery or left main pulmonary artery or main pulmonary trunk or in the lobar branches mainly. But segmental, subsegmental level, I don't think it is not much useful. But it gives more acute result. That means presentation is heart rate, BP, and saturation are like this, and post it is reduced drastically. Heart rate become 117, BP become improved, saturation without oxygen is 96%, and PA pressures are improved immediately. Thrombolysis takes some time improving the PA pressures, but mechanical thrombectomy gives the immediate result. So pulmonary artery pressure was 14 after the procedure. So he was symptomatically better. So this is the ideal case for doing mechanical thrombectomy with Inari catheter, as the patient is having high bleeding risk and the thrombus is located in the main pulmonary tract. Thank you.
Thank you, Vinay. Any comments on the case presented? And in the meantime, while the comments come in, John, if you manage to sort out your computers
Yes,
and
sir. So
log in
we
again.
already have Dr. John's slides. Sir, we already have Dr. John's slides with us. So I will ask
Oh,
my marketing
wonderful.
team to share from the back end. So Mani, can you
Wonderful.
please share that? Yes, sir.
Unshare the Vinay's
Yeah.
screen.
Dr. Vinay, can you please stop sharing that?
Dr. Pippin, your
Thank you.
comments on Vinay's case, there was thrombus only
Yeah, I
on
can
one
share
side.
now. Yeah.
Yeah, so interesting. Few things. I mean, one, the echo result is wrong. So the pulmonary pressure was only 42. So initially, I thought it was
The
a
limit,
case of
and I-
chronic pulmonary hypertension, but actually the invasive pressure is only 42. And in fact, it normalized after thrombectomy. So big change. I
Yeah.
think the clot burden was very big on the right, and that's why the unilateral PE was sufficient to cause so much hemodynamic distress. I think the patient having asthma was the other issue. So she was more symptomatic because she had lung disease superimposed on top of her acute PE. So I think it was a nice case, nice patient selection, and I think very good result for the patient.
Can Dr. Cheda?
Yes, please.
I wanted to make one more comment because it's a way, because both the cases, if you look at them, both of them had a low platelet count and labeled as ITP. In my experience also, lot of these patients, I feel they have a consumption coagulopathy, which is being misread as an ITP. We can ask Dr. Pippin's experience on this because ITP is not the problem. I think it's because of the consumption coagulopathy.
I suspect it's true, and I think, you know, most ITP patients, although the first one had petechiae and all these things, so I'm not sure whether that was real, but certainly we see a drop in platelets in patients presenting the acute PE. The other minor comment I wanted to make on the second case is that I saw the contrast was injected using a pigtail. My recommendation is don't use the pigtail, just inject directly into the sheath, because you've got this massive sheath inside that's going to deliver a lot of contrast in a short amount of time. You get much nicer pictures than injecting into a 6 French pigtail. So just make use of the sheath. You got it there, just use it. And it gives you really nice pictures.
Perfect. John, you can start your presentation.
Yeah. Thank you, and good evening to you all. It's my pleasure to share the experience with Inari at CMC Hospital, Vellore. So I'll be talking about the evolution of catheter-based therapies here at CMC Vellore, and also share some cases of done with the Inari catheter at our center. Just to revise, the Inari system comes with 3 components. We have the Triever aspiration catheter, which comes in sizes of 16, 20, and 24 French. You also have this flow Triever system, which we heard in one of the previous talks. And then you also have this flow saver device, which you can use to collect the aspirated blood. You can filter out the thrombus, and you can inject this filtered blood back into the patient using a separate line. Sorry? Are you able to see my slides?
Yeah, we are able to see, but the slides are not moving.
Okay, I will share again then.
Yeah. Oh, no, don't share again. They're moving now. They're moving now. The person who's moving the slides.
So I do have the share access control. So if the other
no
person
problem,
gets
no problem. Next slide, and you can carry on.
Okay. So
can you see the screen?
I can't see which slide is happening now. Can I?
So he's finished. He's now come to the introduction, and he's shown all flow Triever aspiration catheters. He's shown the flow saver. So that is over. So maybe next slide. You can
okay,
you open
can
your
you
own
see?
presentation in your laptop?
Yeah, I can. I'll open a separate
Yeah,
laptop
please open
actually.
your own
Yeah,
presentation
yeah.
and then keep telling the
So,
individual, go to the next
Yeah.
slide while you're speaking.
yes, sir. So there's a request when you've done like you've spoken about one slide now. If you can just tell me, please change the slide. I'll change the slide.
Sure.
Okay.
I'll do that.
Hmm.
Yeah, so we were talking about the clot the Inari aspiration system. It comes in with the three components: the Trevor aspiration catheter, which comes in 16, 20, and 24 French catheters. And these catheters are highly trackable and flexible. You also have the flow Trevor system and also the flow saver device. And using this flow saver device, you can actually collect the aspirated blood. You can filter out the thrombus, and then the filtered blood can be given back to the patient. So this way you have a bloodless thrombectomy. Next slide. As you all would have realized, the incidence of PE is on the rise. Partly this may be due to increasing awareness and diagnosis post-COVID. But we see that the mechanism of pulmonary embolism is a bit different pre-COVID and during COVID and even post-COVID. So pre-COVID, it used to be mostly embolic from deep vein thrombosis. During COVID time, we used to see a lot of in situ thrombosis. Now we see a mixture of these cases. Mortality nevertheless remains high, about 7 to 10%. Next slide. So we actually started, previous slide, please. So we started our mechanical thrombectomy procedures way back in the immediate pre-COVID era. We initially used the angiojet rheolytic system, and this is the example of a case we done with the angiojet system. As you can see in the picture, this patient has a significant thrombus. In the picture, you have a occluded right descending pulmonary artery, but this patient also had a occluded LPA descending pulmonary artery as well. And we got a really good result with the angiojet rheolytic system. Next slide. But next slide, please. So this patient has recently completed 6 years follow-up, and this is a CT. As you can see that there's hardly any residual thrombus. He did not have any signs of pulmonary artery hypertension. Next slide. But there is a problem with using the angiojet system. We see a lot of bradycardia, and some patient also went into asystole, which means that if you're using a rheolytic system, you need to use you need to have a temporary pacing catheter in the background. And almost all patients will have hemoglobinuria, and if you don't tackle it early, these patients can go into acute kidney injury. You also get a lot of patients with hemoptysis due to some vessel injury, and due to vagal stimulation or distal embolization, some patient can have hemodynamic collapse requiring CPR, and sometimes patient may not survive. And this system was not very effective for large, bulky central thrombus. And as I mentioned earlier, there is a risk for distal embolization. Next slide. So once the penumbra system came, we moved on to the penumbra aspiration catheter. Initially, we've used the Cath 8. Sometimes we actually used 10 French other Cook catheters, etc., to aspirate thrombus from these PE patients. This is one such example. Patient who had bilateral branch pulmonary artery occlusions. Although again, like rheolytic thrombectomy, we were able to get good result with the penumbra system. This system also had some drawbacks. Next slide. Next slide, please. So these were the issues with the penumbra system. If there was a large or organized thrombus, you're not able to aspirate these clots. And usually there can be a significant blood loss. Sometimes if you want to completely aspirate old organized clots, you tend to do a lot of these aspirations and you tend to lose a lot of blood, which can lead to hemodynamic instability. And many a time the catheters will get occluded with clots, and then you have to do this clot fragmentation and stuff like that. And also there's no long-term data with the penumbra system. Next slide. So recently we were able to get the Inari system. By now we have done about 40 cases with the penumbra and the relytic system, and we were quite happy to use this new system. And I'd like to share a couple of cases. This is a first case. This patient is a 35-year-old male diagnosed with acute pulmonary embolism. And here in CT, you can see a thrombus in the main pulmonary artery going into the bilateral main branches and extending down into the upper lower segmental and subsegmental branches. His cardiac enzymes are high, BNP is high. He also has slightly elevated lactate level. And he also has several comorbidities. And considering his high clot burden and intermediate to high risk category, we decided to offer him a mechanical thrombectomy. Next slide. Next slide, please. So this is the first time a 16 French Trevor aspiration system was used in our country. And as you can see from the hemodynamics, we were able to get a good reduction of the pulmonary artery mean pressures. Next slide. So pre-procedure angiogram, you can see in the main right pulmonary artery is a significant clot, and the right descending pulmonary artery is occluded. You don't see the upper branch as well. And on the left side, again, you can see a significant large clot in the left lower descending pulmonary artery. Next slide. So this case, we decided to use the 16 French system, and these are the results post aspiration. You can see that we have managed to get a very good result. We also went into each of those middle, lower, and even the upper pulmonary artery. The post right picture is actually the catheter into the middle and the lower branches. And you can also appreciate that this catheter is quite flexible. You can see this alpha loop of the 16 French on the picture on the left. And similarly, on the right side, we were able to get a very good resolution of the thrombus. Next slide. So this was the thrombus material that we aspirated. You can see here that they're not just clot, they're actually organized and fibrous clot. And you can see the amount of material that has come with this 16 French Inari system. Next slide. So next case is that of a 48-year-old female, again, acute sudden pulmonary embolism. This lady also had a saddle thrombus, as you can see in the CT. She again had several risk factors. And on angiography, you can see the big thrombus, chunk of thrombus sitting across the right main pulmonary artery. The right descending pulmonary artery and the middle branches are not seen at all. A little bit of thrombus extended into the left pulmonary artery. Next slide. And this is the result we got for this patient. Initially, we tried using a 16 French system, but we couldn't suck this clot from the main right pulmonary artery. So we had to use the 24 French system. And this is the final result of using in the 24 French system. So what we learned from our experience is the main branches, it's good to use a 24 French system. Next level, you could go up to a 20 French curved system, and then the deeper branches, it's good to use the 16 French system. Next slide. So overall, we have done about 10 cases. None of our patients have died. No patient had any significant hemodynamic instability or bleeding. Most of these procedures were very quick. Patients had short hospital stay. And on follow-up, all of these patients have remained asymptomatic. Next slide. So in conclusion, what I want to say is that in most cases, the pulmonary embolism is acute or even subacute, but the clot, what is there in the pulmonary arteries are often, they are quite chronic and fibrotic. As you've seen in our cases, they're like a tube, organized tube. And this is the reason why thrombolysis don't work. And if thrombolysis don't work, the chronic anticoagulation also may not work, and many of these patients ends up with chronic thromboembolic pulmonary artery hypertension, and we do have a subset of these patients in our clinical OPDs. So Inari system happens to be a promising tool in this landscape, and you could use it for acute submassive pulmonary embolism, and even for massive pulmonary embolism where patients are stable enough to reach the cath lab. And we have used in thrombosis which are like fresh or even very old and chronic. And this system provides a very large bore and minimal blood loss mechanical thrombectomy. The advantage is that removal of thrombosis is quite quick. There's hardly any hemodynamic worsening, and you don't require a long ICU stay. And this is particularly useful in patients with high bleeding risk. There are some limitation at the moment, the main limitation being cost. And I mean, at least we don't have long-term follow-up in our country. And if you're not used to working with large bore device, especially for venous systems, you could have some bleeding from the femoral size. So with this, I end my presentation. Next slide. Next slide. And I would like to thank my colleague for the support during all the cases. Thank you. So I'm happy to take any questions or any feedback.
Thank you, John. I think what we managed to do phenomenally well is keeping the time. And Dr. Pippin, your final comments for this evening webinar. And if any of the panelists and other speakers want to add on anything, you're all most welcome.
I have one question to Dr. John Joseph.
Please, Vinay, go ahead. Go ahead, Vinay.
Any patients in your experience you had the need of thrombolysis even after doing Inari?
With Inari, we not had to thrombolize at all. But with Penumbra, we really had to, give thrombolytics into the pulmonary artery, like a local thrombolytics. But with Inari system, never. None of the 10 cases required thrombolysis.
Maybe to add to Dr. John's answer, you can do a very good angiogram with the Inari system. So that's number one. And number two, if you measure your pulmonary artery pressure at the end of your case and you have normal pulmonary artery pressure, there is no clot left, there's no obstruction left in the pulmonary system, you will never need to give thrombolysis. That's the benefit of doing this, because you can see clearly what's left. And if you have normal pressure, that's part of our discharge criteria for patient going home next day, because there is no more obstruction in the pulmonary circulation. Right. So, and just to add to that, thank you everyone for the fantastic cases. I think clearly very expert interventionists, very, very low risk, learn very fast. I think it's not hard to learn. I think it's just having the right support and having the right cases to do them on. And I'm sure everyone will flourish. And it's really nice to see everyone's cases.
I'd like to thank everyone for this wonderful evening symposia. And Dr. Pippin, you have kind of simulated us, and we'll get you back periodically to sensitize us, because I mean, your talk was amazing and was an eye-opener, at least where I'm concerned. And we need to sensitize the environment about the goodness which this therapy can deliver. We probably focus on the STEMIs and the acute strokes, but we are kind of neglecting the third leading cause of death, which is pulmonary embolism. And we need to act in this front. So it's been a wonderful evening symposium, staying up with us and educating us, and for making this evening symposia a great success. Thank you, everyone. Any final comments from anyone? If Team Veiva wants to add something, I can see Gauravi. Yeah.
Dr. Chatterjee,
Hi, Deepak. You've been quiet all this evening, you know.
Just a very quick question to Dr. Pipin. It was all awesome cases and it was very informative talk today. Just wanted to know, when you have this most sickest patient, somebody who's had a cardiac arrest, would you put them on ECMO and straight away take them to the cath lab, or would you wait for a while? What is your strategy like?
So I take them to the cath lab because in our institution, we've realized that doing ECMO alone is like a bridge to something. It can be a bridge to thrombolysis, it can be a bridge to thrombectomy, but the patient struggles to come off the ECMO easily if you don't do something to the clot. So we always take them there. Often the ECMO patients don't even have a chance to have a CT pulmonary angiogram because they've just collapsed and you put them onto ECMO. So we kind of use the cath lab as a diagnostic angiogram, and we'll see how much clot burden there is. Usually there is a lot, and we try and clear as much of it as we can. And that allowed suddenly the ECMO works miraculously. They have to turn the flow down, and usually the patient comes off ECMO the next day. So that's the way we work, and that's often when I go jugular because they've managed to use both legs for the ECMO, and there's no space for me to work below. And so that's the reason for me using jugular.
So to answer Deepak's question, like during the penumbra era, we used to have the situation like post, surgery, patient arrest, CPR, no pressures, high inotropes. We used to get these patients, and with penumbra, it takes a long time to remove the clots. And those patients, we have ECMO in our cath lab, and we put them on ECMO, and then we suck out the venoarterial ECMO in this case, and we have to suck out the thrombus. But with Inari, we find the sucking out of thrombus is quite quick, and you may be able to establish hemodynamics, especially if you have a good anesthesia team or backup team.
Thank you.
Okay, thank you, Deepak. I hope your question was answered. So, one final comments from Team Veiva before we close.
Yes, thanks a lot, sir. On behalf of Veiva Scientific and Inari Medical, I extend our heartfelt thanks to everyone who has joined us today for this insightful session. And a special note of gratitude for Dr. D.S. Chadda, sir. It was an honor to have your presence and for you to guide us through our session today. And all the attendees, thank you for your participation, engagement, and your commitment to continuous learning. And very grateful. We are very grateful for all our speakers and panelists for their presence as well. We look forward to bringing you more such sessions in the future. And until next time, thanks a lot. Thanks a lot, everyone. Have a great evening.
Thank you, everyone. Good night.
Good night.